Society is one of the signature institutes and initiatives here at Duke. We offer a master's in bioethics and science policy, a joint JD-MA degree for those of you who are 1L students and are interested in exploring the ethical, social, and policy implications of emerging technologies. I would encourage you to be in touch with Buzz Waitskin, who is the Deputy Director of Science and Society, or Thomas Williams, who is the Director of the JD-MA program. If you are interested in potentially exploring that opportunity to get those degrees at the same time. I'm also delighted to have with us today the new head of our Duke Center on Science, Technology, and Public Policy, who's Matt Perot, who will be joining us on October 10th. After a long stint at Facebook, he's joining the better side in academia to help guide us toward tech policy, which we're very excited about. We have three experts here today leading the charge on issues of e-cigarettes and vaping. As I'm sure all of you are aware, this is an issue that's been all over the news with the increased number of people who are suffering from various illnesses. And the question is this a problem of e-cigarettes and vaping? Is this a problem of our existing policy? How ought we be responding to these issues? And what are the issues, quite exactly? Some of you may be individuals who have tried e-cigarettes or vaping and think that it is a good thing to do and think that it's a safe thing to do. We want to get to the bottom of the facts and also think about what the policy issues should be going forward. We will have three brief presentations. Starting with Dr. Jed Rose, followed by Dr. James Davis, and finishing with Dr. Lauren Pacek, talking about the different aspects and setting the stage for us to better understand the conversation. That's going to happen for about the first 30 minutes. Each of them will speak for about 10 minutes, leaving ample time from 1 o'clock to 1:30 for your questions and engagements, and for me asking questions of them. They have interesting perspectives. There are some of you in the audience who have different perspectives, and we will encourage you to put those perspectives out on the table as well. But just so you have a sense, I'll give you only the briefest bios of our three speakers today, and encourage you to look up their distinguished bios online as well. But we'll start with Dr. Jed Rose, who is a professor in psychiatry and behavioral sciences, and also at the School of Medicine. He's the director of the Duke Center for Smoking Cessation at the Duke University Medical Center. He's also incredibly well known for co-inventing the nicotine skin patch with the late Murray Jarvik in the early 1980s, which helped pave the way for the development of commercial nicotine skin patches. And so he really has a long history of thinking about and being inventive and being at the forefront of what smoking cessation alternatives can be. He holds several major grants from the National Institutes of Health on e-cigarettes, and he conducts a lot of major research on smoking cessation and e-cigarettes. He'll be followed by Dr. James Davis, who's a practicing physician of internal medicine and serves as the medical director for the Duke Center for Smoking Cessation, the director of the Duke Smoking Cessation Program, and the co-director of the Duke UNC Tobacco Treatment Specialist Credentialing Program. His research focuses on the development of new pharmaceutical treatments for smoking cessation. He's a PI on several major trials, including a study on adaptive smoking cessation. He also leads the Duke Smoke-Free Policy Initiative, some of which he can tell us about today and some of which he can't tell us about today. And we'll ask what we can and push him on the areas that he can share with us. He's the co-author on National Tobacco Dependence Treatment Guidelines, and he provides training in tobacco dependence treatment at the Duke School of Medicine, Duke Internal Medicine, Family Practice, and Psychiatry residence programs. And rounding us out will be Dr. Lauren Pacek, who's an assistant professor in psychiatry and behavioral scientist. She conducts major research on the epidemiology of tobacco use among vulnerable populations, with a particular focus on persons living with HIV, epidemiology of substance use and substance disorders, tobacco regulatory science, and harm reduction. She's an expert on the implications of new laws governing e-cigarette use. You may have seen the significant profile piece that was done in the Duke Chronicle on her research and on her study, looking at and helping us frame what we ultimately titled this, which is the crisis or lost opportunity, given the framing of her study, to think about what are the implications if we go down this road of outright bans. Is that really what's best for harm reduction in society, or are there different ways that we ought to be thinking about this? So to kick us off with this complex topic, Dr. Jed Rose, thank you.
Thanks very much. And just another quick word about my background. I got into the tobacco addiction research field in 1979, so it's been just about 40 years. And as was mentioned in the early 80s, followed up with an idea from one of my brothers, actually, to explore transdermal nicotine administration, and led the first studies and named as lead inventor on a number of the early nicotine patch patents. Then in the late 80s, colleagues and I, which included Ed Levin, who's at Duke, and Frederic Bem, we looked at the approach of combining nicotine with a nicotinic antagonist, which was the precursor to the partial agonist approach to smoking cessation, and Pfizer credited us with helping to inspire them to develop Chantix. But after decades of exploring and continuing to explore pharmaceuticals such as pills and patches to help people quit smoking, I've been forced to open my mind to the conclusion that smokers are as addicted to the habit of puffing and inhaling smoke into their lungs as they are to getting the chemical nicotine into their bloodstream, into the brain. And that there is an important role for inhalational substitutes to help smokers quit and provide long-term reduced risk substitution strategies. And in that context, I've found it actually helpful under certain circumstances to collaborate with scientists in the industry, e-cigarette or tobacco industry. And so my second slide, that is, talks about disclosures in addition to my history of funding with the National Institute on Drug Abuse. Before that, the American Cancer Society. I've also done e-cigarette studies and with industry, and the important thing is that the only collaborations that I do engage in with the industry are on reduced risk products. Anyone who wants to read more about the arguments for and against working with industry in this fashion, and I, along with other luminaries in the field, such as Jack Henningfield, who was a key contributor to the 1988 Surgeon General's report on nicotine addiction, and Carl Fagerström, Saul Schiffman, other important leaders in the field, have all come to the same conclusion that the enemy is public disease and death, and not necessarily individuals in an industry. And we may have to work collaboratively to end the huge epidemic, the true epidemic of cigarette-related disease and death. Well, so let me just deal with a few questions in rapid succession. The first is that you may have heard that there's this huge controversy over whether e-cigarettes can help anyone quit smoking. And I think that's been exaggerated, because when you look at the evidence, it's actually fairly convincing that e-cigarettes can help people to quit smoking combustible cigarettes. There is, first of all, just the basic notion that every single form of nicotine replacement that has ever been studied, whether it's patch, gum, lozenge, nasal spray, or the vapor inhaler, which involves puffing on a device and inhaling. It doesn't give enough nicotine to be all that effective, but nonetheless, all of these methods have demonstrable efficacy in helping people quit smoking. So it would be really surprising if e-cigarettes that deliver nicotine had no efficacy in helping anybody to quit. But in addition to that a priori notion, there are actual randomized controlled clinical trials showing that e-cigarettes help people quit. Cochrane reports, independent reviews have shown that even the early first generation e-cigarettes, which weren't all that effective at delivering nicotine, nonetheless were about as effective as a patch, and more effective in terms of causing significant reductions in smoking. Then recently, and I know Dr. Davis will expand on this, New England Journal of Medicine clinical trial by Hayek et al. Showed that e-cigarettes were twice as efficacious as current state-of-the-art nicotine replacement treatment. So about 18% one-year success versus about 10% with state-of-the-art combination nicotine replacement therapies. Interestingly, a lot of the successful e-cigarette users continue to use e-cigarettes at 1 year. So the notion of long-term substitution may underlie a good deal of the potential benefits. And then that raises the question of whether it's how much harm is there in continuing to use e-cigarettes year after year. And to attack that question, we have to keep in mind that pretty much every expert, including the Surgeon General's report of 2010, concluded that it's not the nicotine that is the cause of most smoking-related disease, but rather the products of combustion, the burning of the tobacco. There's carbon monoxide, there are carcinogens, a number of inflammatory compounds, and that those are the real culprits. Nicotine's addictive, but it's the other agents that kill most smokers. And when we think about vaping or e-cigarette use as harm reduction, we should also not make the mistake of saying that vaping is the same as breathing clean, fresh air. I don't think anyone is claiming that vaping or anything is 100% safe and clean, but the toxin exposure from vaping is far, far less than from combustible cigarettes. I'll refer you to a study by Gonowitz et al., which measured a number of known tobacco-related toxins in cigarette smokers and users of e-cigarettes, and found for most of them there were enormous reductions in exposure when people used electronic cigarettes compared to combustible cigarettes. And in addition to just the toxin exposure, there is a growing amount of evidence that's showing real benefit in real smokers. Ricardo Pelosa, a pulmonologist in Sicily, studied smokers who switched to e-cigarettes and measured lung function parameters and found that over 1 year they had improvements in lung function and reduced respiratory symptoms. A lot more research of this type needs to be conducted, but so far the indications are that vaping is substantially less harmful than cigarette smoking. And a number of modeling efforts have been done. David Levy at Georgetown University estimated, even under the worst case scenario, that assumed that e-cigarettes might be 40%, almost half as bad as combustible cigarettes, which virtually no one in their right mind believes, but all the way to the more optimistic scenario that they're far, far less harmful, and including effects on teens, taking up the habit, possible gateway effects, and anywhere between 1.6 million and 6.6 million fewer deaths could be achieved in the United States over 10 years if every smoker was to switch to e-cigarettes. There's virtually no plausible scenario where e-cigarettes can have a negative public health impact. So these technologies, and there are a number of related technologies for delivering nicotine without combustion products, have enormous promise for not only smoking cessation, but for saving millions of lives. So what about this current crisis of pulmonary disease, which as of yesterday, CDC had reported 805 cases and 16 deaths. The vast majority have been associated with concurrent use of THC or CBD products. It's almost certain that there's some form of contamination that is causing a sudden outbreak after millions of people have used e-cigarettes for years and years, and then all of a sudden there's this rash that's localized mainly to a very discrete source of THC-type products, not exclusively, but mostly. It just smacks completely of contamination. We should think of history here. There have been cases where contaminated alcoholic beverages have killed people, methanol contamination of ethanol-containing beverages. 31 deaths going back to the 60s in Philadelphia. More recently, 2016, a mixture of Mountain Dew and methanol, referred to as Dew Shine, resulted in deaths of 2 Tennessee high school students. And even just last year, a Massachusetts man died after ingesting alcohol that was contaminated with methanol. And this is not even including the more than 2,000 people who die of just the ethanol in alcohol beverages every single year from alcohol poisoning, many young people included. But do we hear calls for a ban on alcohol, a ban on flavored alcohol? No, we talk about regulating and regulating content and contamination. Again, to put things in perspective, here's the annual death toll in the US from a number of sources that I pulled off the web. Cigarette smoking, you often hear the figure of 480,000 deaths a year. According to Carter et al. In the New England Journal of Medicine, it's more like 540,000 deaths every year, which is a staggering figure. Drug overdose, 70,000 a year. Gun violence, over 30,000 a year. Alcohol disease, 88,000 a year. Motor vehicle accidents, over 30,000 a year. When I plot vaping there, if I put the 16, it wouldn't even show up on the scale. I had to multiply by 1,000 to get it to be 16,000, so you could actually even see it. Another tragic case of death is the soft bedding, and sheet entanglement can cause death in infants. 170 infants die every year in the US from this kind of suffocation. So are we talking about banning soft pillows? Banning the sale of soft pillows? I don't think so. And yet we're talking about banning e-cigarettes. Here I plotted on a more reasonable scale the deaths from vaping so far, and that number is climbing. The infant deaths from loose bedding. Let's not forget about Tylenol poisoning that kills hundreds of people every single year in the US, but we don't even talk about that. And these deaths from vaping are almost certainly going to be curtailed once FDA and CDC identify the sources of contamination and institute regulatory controls. The way to make it go higher is to start banning products, encourage a black market, which is going to further contaminated sources being sold and distributed. Finally, what about the youth epidemic of addiction that we keep hearing about? Well, you hear a very selected and distorted set of statistics. Usually you hear about has youth ever vaped or vaped in the last 30 days. But what about addiction? Addiction is not using something once a month. It's using something usually several times a week or even daily. So David Abrams, a very credible tobacco researcher who analyzed the most recent National Youth Tobacco Survey, found that if you group middle and high school students together, and admittedly, 12th graders are going to have a higher prevalence than 6th graders, but middle and high schoolers as a group, that 86% had never vaped, 13.8%, almost 14% had vaped in the last 30 days. But of those, roughly 14%, almost 10% were already using other tobacco products, cigarettes, hookahs, and smokeless tobacco. Only 3.9, essentially 4%, were tobacco naive, and 3/4 of those were actually vaping less than 5 days, less than or equal to 5 days a month. So the bottom line was that only 0.4% of middle and high schoolers were both tobacco naive and vaping on 20 or more days per month. 0.4%. Is that an epidemic? I don't think so. So I think in conclusion, people are trying to spread fear and exaggerate the risks and dangers without recognizing the huge potential value in saving lives of new technologies. And what is really needed is not more hysteria and fear mongering, but rather intelligent educational efforts and regulation by FDA. Thank you.
No, I don't think so. And this has a pointer also. So I want to, and let me just say that a number of things that we're going to say are going to make you feel like asking questions perhaps, or raising objections even. It would be helpful for us to get through the end of our presentations and then speak after that. I'm going to say a couple of things that I think really echo what Jed said. And actually, first, let me just say that Jed and I work together. He's been in the field a little longer and has a vast wealth of experience. My perspective is a little different, and that's that I work directly with patients, and I conduct research, I do pharmaceutical work, but I spend a lot of time working with individuals, and it gives you kind of a feet on the ground sense of what's happening, and I want to share a little bit of that perspective as well. Here's the 480,000 people per year dying of smoking, and 30% of all cancer deaths in North Carolina are directly attributable to smoking. And the reason that I bring up smoking is that, and again, I'm involved with policy discussions at the university level and elsewhere with e-cigarettes. And the reason that I bring this up is that e-cigarette use does not occur in a vacuum, and this whole policy issue does not occur in a vacuum. And I think on an academic campus, we may lose the sense of how large an impact combustible smoking actually has in the US. Part of the reason is that it's going on in low SES populations, disadvantaged populations. When I looked at professors here at the university, 1.3% of faculty uses tobacco. When we go to disadvantaged employees and people who are on campus but are not, we've got 30% of those folks who are using tobacco, very high rates. In my clinic, and I've been working with people who use tobacco now for 10 to 15 years, if any of you could sit with me for an afternoon and see smoker after smoker come in, and I don't mean to be emotional, but it is heartbreaking. It is absolutely heartbreaking. They come in after heart attacks, after strokes, with diabetes, which is now connected to smoking as well, with all kinds of forms of cancer, and their lives are just being destroyed. Now, 50% of people, it looks like around 51% of people who smoke will die of these illnesses, die of illnesses related to tobacco, die because of their smoking. Far many more people will suffer all kinds of morbidity associated with this. Shortness of breath, it just goes on and on. And so when I think about e-cigarettes, I think about this population and how many people out there are in fact smoking. And again, I just want to say, e-cigarettes are an issue, and e-cigarettes need to be taken up from a policy perspective, but e-cigarette use is not occurring in a vacuum. It's occurring in a population where we have all these people who are suffering and deeply addicted to tobacco. I'll say one more thing that's not on my slide, and that is that the abstinence rate for somebody who tries to quit tobacco is 3.5%. Okay, I'll say it again. The abstinence rate for people who try to quit smoking is 3.5%. That means when people say, oh, I know I gotta kick the habit, chances are they're not going to be able to. That's what we're up against. When we get people on medications, we get that up to around 10%, 10, 11%. Now, e-cigarettes have come into that situation as a way for people to quit that may be more effective for some people than those medications. We'll talk about that in just a minute. So, lots of e-cigarette, about 12 million e-cigarette users in the U.S. The long-term morbidity and mortality is really unknown here, and I think that is very important. And in science and in general, we want to be conservative. We've got, like Jed was saying, 16 deaths right now, but we do not know in 20 or 30 years what we will actually be seeing. And I think there's some humility that's needed there, and that I think that we all in this field really have about this. The toxicity for most of these compounds is about 5 to 10% what we see in cigarettes. I wrote these slides a couple of days ago, so the death for lung injury syndrome is going up. It's about 16 now. E-cigarettes, and I think Jed said this well, and I'll say it in its super simple terms. Nicotine is highly addictive, but by and large it doesn't kill you. The compounds of combustion, the smoke that you get from cigarettes, absolutely kills you. That's what we have. With e-cigarettes, we do not have combustion. We do not have the smoke, but we have something that is highly addictive. And we are now beginning to put together a picture of toxins that are a part of e-cigarette. It looks like there's toxins that are much lower level than cigarettes, but they're absolutely present. So right now, about 30%, a little more, of smokers will try to use an e-cigarette to try to quit smoking. Only a little more than 13% will use medications to try to quit smoking. Who's using e-cigarettes? We've got about 3.6 million children in middle school and high school. That's a lot. That's that 30-day, have you used in the last 30-day question. 4.9, 20.8% in high school students. This really brought this subject into the news. When we saw those rates go up so dramatically, this really brought e-cigarette use into the news. And I think Jed provided a nice kind of perspective on that data to say that, you know, when you look at people who are only using e-cigarettes and who are using it daily or frequently, this number is much lower. For adults, and this is really two different populations, for adults, people over 44 years old, almost 100% of e-cigarette users really are smokers, and they are trying to get off cigarettes. Some of them are successful. Many of them actually try to get off of e-cigarette, try to get off of smoking, and they end up using both. They end up using both cigarettes and e-cigarettes, though some of them make the transition completely. Among youth, about 60% of e-cigarette users were smokers. Here is what happens when you use e-cigarettes, kind of in a clinical setting, I should say. If you were to go to a doctor and the doctor says, here's an e-cigarette, try to use this to quit, and here's I go to another doctor, gives me nicotine replacement. The abstinence rate for e-cigarette is higher than that of nicotine replacement. However, at the end of this study, and Jed mentioned this, at the end of this study, 3% of people who were given regular medications were still using those medications. A year later, 82% of people using e-cigarettes were still using e-cigarettes. What that means is that when you quit using an e-cigarette, what you're doing is transitioning to something else that's addictive. You're transitioning your addiction to something else. Now, there's a harm reduction argument there, but that's the way we think about it. Here's this syndrome. So when we look, what is causing this syndrome, pulmonary syndrome? This is a CT scan, and these folks, let me just say, these folks are really sick. The great majority end up in the hospital. Over 50% end up in the ICU. The average age of these folks is about 19, so these are young people, and they are crashing really hard. They have high fevers. Their lungs are absolutely filled with I'll say crud. It's a large, a lot of different things. This is a really ugly syndrome. It looks like the majority of these folks, like Jed said, this may be related to THC or CBD oil, other constituents that they're putting into their e-liquid, and they're putting into their e-cigarettes, and that's contaminating the e-cigarettes. But there's a portion where we don't really know what's happening, because there's a portion that reported nicotine use only 17%, and this is from the New England Journal of Medicine. Later on, it found that among these 7 people, 5 of those 7 eventually said, yeah, I was actually using THC. I still want to be very careful about this, because I don't think we can we're early on in understanding this. I think Jed's kind of statement that this looks like an outbreak, people have been using e-cigarettes for a long time, this looks like an outbreak, is true, but these people get really sick, and that's not something to sneeze at. So, e-cigarette policy. There's so many policies that are coming forward in so many different places. This is just a sampling. Here, the UK Ministry of Health recommends that we should be using e-cigarettes to try to quit smoking. That physicians in the UK it's recommended by their government that they prescribe the use of e-cigarettes. So that's the UK. Here in August of 2016, FDA deeming rule. This is the Center for Tobacco Products has the authority over e-cigarettes. It's illegal to sell it to minors. Must submit ingredients. Lots of inspections of manufacturers. A warning label placed on things. And then these products that have been deemed vaping products must be submitted for a pre-market tobacco product application. That's happening in very soon, May 12, 2020. At that point, a lot of these mom and pop manufacturers are not going to be able to put that application together. It's a huge application. So we'll see a lot of the smaller providers falling off. San Francisco bans e-cigarette use. India bans e-cigarette use in September. That just happened. And then we have Trump's request to ban on e-cigarette flavors. So I am also involved, and I've been involved in the Duke smoke-free policy. and was able to get that off the ground with Gene Washington and some other folks, many people at Duke. This was a concerted effort with lots of debate among students, among graduate professional students, among the academic council, and many groups around campus. And we started essentially with the realization around e-cigarettes that it's impacting two different populations very differently. We have a bunch of people on campus who currently smoke, and they are not able to quit. And we thought, okay, those are employees who smoke. We don't want to ban e-cigarettes because e-cigarettes are one route through which they may be able to stop smoking and at least use an e-cigarette on campus. With students, we want to go after e-cigarette use. We really want to attack it, and so we want to go after it through an educational campaign, a raising awareness campaign. I was just given. I've been in conversations recently about this, about the lung injury, development of lung injury related to e-cigarettes, and I was given permission an hour ago to share with you all that the university is now taking the e-cigarette policy under consideration, as that we are now shifting, we are now reconsidering our approach. I can't say where we're going to end up, but the approach had been, we're banning combustible tobacco, but we're not banning e-cigarettes. That is now under consideration. So we are moving, and it has to go through a number of steps. And that is really related to e-cigarettes seen as, with this lung injury syndrome, seen as a kind of public safety event that we need to work with. So I think that's about all I can say about it. That's all. Thanks.
So I just want to present some data that might be useful for regulatory decision making, and data from some studies that have tried to anticipate what the outcome of a flavor ban might be. But also before I start, I want to clarify what I mean whenever I say flavors. In this context, unless I say otherwise, when I say flavors, I mean anything other than a tobacco-flavored e-cigarette product. So we know that flavored e-cigarette products are very important to youth use. Most youth who have used e-cigarettes indicate that they initiated their use with a flavored e-cigarette and that they also still currently use flavored e-cigarette products. A majority also indicate that if flavors were no longer available, they would not use ends anymore. We also have preliminary evidence from a hypothetical choice task indicating that if you restrict ends flavors just to tobacco, it might reduce the uptake among youth. So if the goal of a flavor ban policy is to reduce use among youth, there's some indication that this might be helpful in that respect. However, we also need to be really aware of the impact that such a regulation might have on other populations. Because we know that even though flavored products are really important to youth use, they're also very important for adults as well. Even though most adult e-cigarette users indicate that they began using e-cigarette products with either a tobacco or a mint or menthol flavored product, the majority report that they currently use other flavors most often. Former smokers who had used e-cigarettes to help them with their cessation attempts report that not only the availability of flavors, but the sheer variety of flavors that they had access to were really important for aiding in their cessation attempts. And we also have some evidence that suggests that the use of flavored ends products specifically is associated with reductions in the number of cigarettes smoked per day by smokers, and also with increased cessation. And similar to the data that we have for youth, data from hypothetical choice tasks indicate that restricting ends flavors would potentially result in decreased choices for ends products. But at the same time, They may also have the unintended consequence of increasing choices for combusted cigarettes. So to further explore potential unintended consequences of flavor regulations, I just wanted to kind of quickly share some recent work done by my colleagues and myself that was just came out in the journal Substance Use and Misuse, where we conducted a survey via Amazon Mechanical Turk, where we recruited a young adult, so age 18 to 29-year-old, dual users of both e-cigarette products and regular cigarettes. And we had asked this sample to imagine a world in which a variety of e-cigarette product regulations were enacted. And in this instance, what I'm going to tell you about right now is we had asked them to imagine that the only e-cigarettes available on the market were available in tobacco and menthol flavors only. Flavors no longer existed. And we asked them separately, in that world where flavored e-cigarettes no longer existed, what would they do in terms of both their e-cigarette and their regular cigarette use? Would they quit, reduce, maintain, or increase their product use? And so, the light, I want just to orient you to what you're seeing here. The lighter bars are relevant to e-cigarette use, and the darker bars are relevant to regular cigarette use. And even though under a hypothetical flavor ban, significantly more participants indicated that they would quit or reduce e-cigarette use, which based on some of the data that I showed you on the prior slides is not surprising. If you look over here to the boxed in bars, a significant proportion of respondents also indicated that they would increase their regular cigarette use, which of course would be an unfortunate unintended consequence of such a policy. So the take-home message really is just that regulators and policymakers need to be really cognizant of not only the impact that regulations may have on the targeted tobacco product, in this case, e-cigarettes, but also really need to think very carefully and thoughtfully about the impact, the off-target impacts that a policy might have on the use of other tobacco products, particularly combusted cigarettes. And so, of course, there are a number of caveats to the work that I presented. Some of it's based on survey research, some of it's observational, some of it's based on hypothetical tasks or online samples. But just to give our center a little bit of a plug while I'm here, we have a number of projects that are either going to be starting very soon or have already started, where we are attempting to assess the impact of a flavor ban in e-cigarettes on actual tobacco product use behavior. So bringing folks into the lab and seeing how banning flavors might impact not only their e-cigarette use, but also their combusted tobacco product use as well.
Questions, because I know many of you likely have questions. I want to thank our panelists because this is exactly what we hope to do at Science and Society, which is to bring the issues, the facts to bear on questions of law and policy so that people can actually have the facts and be informed before jumping into those conversations. I want to start with my question that emerges from this, which is I'm convinced from speaking with all of you before today as well as today that combustible smoking is very bad, and that e-cigarettes are better than combustible smoking. What I don't know is, I know nicotine is addictive. I don't know what that means, right? So you tell me that deaths don't follow from nicotine. Should I think about nicotine like opioids as a gateway drug that leads to heroin and death? Should I think about nicotine as it's addictive but we shouldn't care that it's addictive? How ought we think about it? Particularly given that we have this population of young people who might, and based on the surveys, it looks like a very small number so far, but if we think about many of these manufacturers as targeting young people with flavors or with marketing kind of protocols to get them hooked early, they may be nicotine naive or tobacco naive people who start with e-cigarettes. Small based on your data right now, but that might be a trend that we would need to worry about. So how should we think about, if it's just the population of people who are e-cigarette users who never go to combustible products, how should we think about the nicotine addiction and the implications of that?
Well,
please go ahead.
I think that I would speak for myself and my colleagues that none of us would want teenagers to get addicted to any substance. I mean, I wouldn't favor being addicted to caffeine either. And yet, actually, a lot of society consumes caffeine regularly, and there's actually an addiction syndrome, a dependence on caffeine. So I think if it turns out that nicotine has as little risk as many speculate, and there are still questions, the problem is it'll take many, many years to really nail it down. But as far as we know now, the risks of nicotine are a very small percentage of the risks of smoking. So it really does get down to your value judgment about whether addiction per se is a huge problem. And in terms of the gateway, though, there's really no credible evidence for much of a gateway from e-cigarettes to cigarettes. Just witness the fact that
what about to other drugs? So opioids to heroin. Is there nicotine to anything else? Or?
Yeah, well, just in terms of smoking, as e-cigarette use, kind of relatively speaking, skyrocketed over the last several years, the rates of combustible cigarette use have plummeted and are at historic lows among youth. And in terms of use of cocaine, heroin, and so forth, the fluctuations that one has seen historically in those make it seem rather implausible that e-cigarettes are contributing much to that, right? You see just year-to-year fluctuations about which drug is popular, and so it doesn't mean there's not some little gateway, but in the scheme of things, again, that's kind of looking at the microscope at something that, from the certain public health knowledge of the, again, 540,000 deaths a year in the U.S. alone from combustibles, these other things, I think, could be managed without stamping out e-cigarettes.
And so, if underline what you just said, you would put nicotine in the category of a caffeine addiction or a sugar addiction, and not an opioid addiction. Is that fair?
Well, I would
Based
say
on current data.
Yeah, I would say it's different from all of them, but not an opioid addiction in the sense that the withdrawal syndrome from nicotine is nowhere near as severe acutely as it is from opioids, and the fact that it's legal means people don't have to engage in stealing to support an illegal, let's say, heroin habit. And, heroin on the street, because it's illegal, is subject to contamination with fentanyl, which is killing many, many thousands of people every year.
But we go to legalize all drugs, right, based on some of these arguments. So I'm more just asking the question of trying to understand, and it sounds like we don't have any good, solid data, other than it is addictive, to what the harms of nicotine alone are. Is that fair?
Yeah, other than that, that the lung health study, for example, that followed thousands of people using nicotine gum, which admittedly is not inhalation, but still chronic exposure to nicotine, found not even a hint of a signal in terms of either cancer or heart disease. People who use Swedish snus, who are exposed to high levels of nicotine chronically, show only a couple of % of the disease risk of cigarette smoking. So from that standpoint, and again, the caveats that nicotine in the lung could turn out to have somewhat different effects, but in general, the best guess, and all you can do is make the best guess based on what you know, is that it's probably, probably worse than caffeine, but maybe not by that much.
Okay. And both agree, or Lauren?
Yes, I agree largely. We're talking about an adult population of nicotine users, but would like to note that nicotine can have adverse effects on the developing brain.
Great.
Yes, absolutely, yes.
Yeah, and that's part of the concern, right? I'm trying to come up with a policy here, figuring out, are manufacturers targeting youth, right? And are there implications for brain development or other long-term health implications versus the population of individuals that are trying to go through smoking cessation, right?
Right, and if you Google caffeine and effects on the developing brain, you get a lot of hits also, by the way.
Not yet let our 4-year-olds have coffee for that reason, but yeah.
Yeah, I was just going to say, I think this is important because there's a lot of confusion about the idea that if it's addictive, it's bad, and I don't want to say if addiction is good, but when I think about a substance, an addictive substance, part of it is the addictive quality of that substance, which is how hard is it to quit once you've started. And nicotine is phenomenally addictive, really impressively addictive. It is in the level of opiate use in terms of how hard it is to quit. The other is what is the associated morbidity and mortality associated with that substance. And with cigarettes, it's impressive. And with e-cigarettes, it's less, but I want to kind of also say, we still don't know. There's still a kind of a question mark around e-cigarettes because we don't have long-term data yet around e-cigarettes. It certainly looks like it's less.
I know that there are a lot of passionate questions out there already, so I'm going to go ahead and call. Before you even, there was there. Yes, go ahead.
Oh, sorry. So it's definitely been established that like a nicotine addiction carried out to e-cigarettes is far less harmful than a combustible cigarette habit. But like, I think I bring a unique perspective to the conversation because I was a sophomore in high school when this like trend really came on the rise. Like the juuling trend, I call it a trend because like in a lot of ways it's like cool to like jewel and like use like vaping products. One of the first places, yeah, it's
Good marketing campaign. Yeah.
it was like New Trier, Chicago, so like a really affluent suburb of Chicago was like one of the places where this really popped up in a big way. And like I've seen people start vaping because like the mango flavor and the convenient USB design, and it's just like it's so cool and fun to like get a buzz. And then start using cigarettes because it's so inconvenient to when you're under 18, like order jewel pods online without your mom finding out. So you start buying packs of cigarettes. And I think that part of the reason for that like 0.4% statistic is because a lot of students that are tobacco naive, that's because they've started using tobacco because of the inconvenience of continually procuring pods and stuff. And then also the epidemic as far as like the deaths, I think, at least from what little statistics we have, it's because like hacking jewel pods and other vaping pods has become a big trend, so you can illegally procure THC oil from like dealers who sell like carts, and then you like open the pods for your jewel or whatever vape you have, and you put the THC oil in, and that's how these people are starting to like die. So my concern is a little bit less with the adults responsibly quitting their habit, and a little more with really illogical teenagers who are just looking for like the next way to get a better buzz.
Mm-hmm. Yeah. Any of you want to comment on that?
Well, that's where I think the education campaign has to come in, that really teaches kids that nicotine in that form is of inhalation is highly addictive, and that getting a buzz is not as simple as getting a buzz and you're done, that you really do face the possibility of lifelong addiction. That won't stop everybody, but again, that 0.4% were the people who were very frequently vaping who had not been exposed to other tobacco products. 3/4, I think it was 3/4 of the vapors had already been previously using the tobacco products. So experimenting with a lot of different things, basically. And I think what there's the danger of the unintended consequence that by squelching the e-cigarettes, that it is going to but encourage kids to turn more to the traditional and deadlier sources of tobacco addiction.
I want to add one thing, and that is that I'm glad you mentioned this dropping, where people are putting substances into, they're hacking their e-cigarettes and putting substances in. And the use of THC, CBD, and other cannabis products at Duke has been well founded at this point. Everybody kind of knows that happens. And that's one of the concerns that the administration has, is that by allowing e-cigarettes, we may be opening the door to people experimenting with these kinds of things that are probably extremely dangerous. Dropping THC oil and inhaling the vapor off the coils, that's some pretty noxious stuff.
Yeah, which you would hope the epidemic, if it does anything, it at least educate people about what the implications. If it turns out it's contaminants, if it turns out it's the hacking and the oil that people are now inhaling into their lungs, ideally there's a significant education that will follow from it. Question?
Hi, I'm Farahany. I'm a tobacco regulatory scientist working at Nita. So I have a couple of things. Actually, the youth use among high school children has increased actually to 27.5%, actually according to the new NYPS data, and within the last 2 years, the daily e-cigarette users has actually doubled. But that was another comment from the data that you showed. But I also wanted to ask you more about the recent Adam Leventhal's paper, where they show that like, the adults who are about 35 years old, the e-cigarette use for the last 5 years, this is a national survey that they did, the e-cigarette use did not change at all. It stayed very stable, or it actually reduced among adults. The only place that increased was among 18 to 29 years old, that it doubled the e-cigarette use in the last 4 or 5 years. I'm not talking about actually the young school-going children, but I'm just trying to understand, like, if e-cigarettes are really the ones that are helping to quit, why is the adult people, the use of adult people who are using e-cigarettes is not increasing, and it's actually staying stable or reducing? The other question that I actually have was, 52% of the people, again, this is from Milo Benovic's paper that just came last week, where they show that like 52% of the people right now are dual users. So there is, and the estimation is anywhere between 2/3 to 50% of the people who use e-cigarettes are dual users. So why is that, like, we are trying to say that like e-cigarettes are helpful for quitting, but we see a lot of dual users? And why in the adult population we don't see an increase in the e-cigarette use in the last 5 years of use?
Yeah, so if I can tell, first this 27, 28% figure, we have to stop focusing on this 30-day use.
Let the panel speak.
Right, because again, it's selectively focusing on a use that is not addiction. A once a month use is, I don't think anyone would classify as addiction. And whether it's 0.4% or whether that has doubled to 0.8%, and whether it was 0.8% the year before, went down to 0.4, and now up to
There are
20.
12% daily users among high schoolers now. So that's just
12% daily
Yeah.
users. No, but most, 3/4 of them were already using other cigarettes and other tobacco
maybe they
products.
smoke once in their life. That's what I think, right? So
Well, but they
then
still
you-
have
then
prior use.
I mean,
Pause, thank you. We'll come back, I'm happy to take your
Yeah,
question.
so in terms of what comes first, in roughly 3/4 of the time, it's other tobacco products. So yes, so maybe it's 3 or 4% of, again, 12th graders, and that's another discrepancy is the figures that were collected by the NYPS were middle and high schoolers. Sure, as you go each year, you're going to get increased frequency. So when you go to the 12th graders, you are going to get a higher rate than 6th graders. But even in 12th graders, it's only about 4% of naive people getting addicted. Now, I'd rather that be 0, but is 4% even a dangerous epidemic to society? I think it's hard to argue that 4% is a dangerous epidemic to society. In terms of the other dual use issue, we're actually conducting studies right now to facilitate complete transition to e-cigarettes from combustibles using behavioral science to devalue the combustible cigarette. One simple method we're right in the middle of testing is where we ask smokers who are trying to give up combustibles is if they feel they have to have one of their own combustible cigarettes, use an e-cigarette immediately beforehand. And what happens is then they don't like the cigarette anymore because they just filled up on nicotine and the sensory and habit stimulation of inhaling the e-vapor. And we think that may have promise to help extinguish the combustible cigarette use. But there are a lot of methods that could be applied to trying to get 100% conversion, not just the 50-50 you're talking about. Dual use is a problem, but it's a problem like any other that we can keep working on.
Right, and just to piggyback on the dual use issue, I just want to highlight that I don't think anyone is saying that e-cigarettes are sort of a magic bullet in terms of completely transitioning folks off of combustive products. We also need to think about users' motivations for using the products. Some people are using them because they want to transition completely. Some are using them because they want to cut back, but others are using them because it's easier to use an e-cigarette in places where you can't smoke. You can vape very discreetly in a bathroom. Can't smoke there. So I think that, yeah, that 50% to 2/3 of people who are dual users, it's kind of a mixed bag for why they are dual users.
Let me do a rapid fire round, and I know there are a number of questions. We have 5 minutes left, so I'm going to take 3 just questions and comments in a row, and then I'm going to give each of the panelists an opportunity to respond. Yeah.
When it comes on smoking cessation, it seems like a lot of your research does, would it make more sense to possibly reclassify e-cigarettes as some sort of medical device that can be specifically used for the treatment of smoking cessation, as opposed to like a recreational product. So you could actually go to your doctor, you say, I have an issue with smoking, I have an issue with using Juul, or sorry, I have an issue with smoking, and you could potentially be prescribed a medical device, and that medical device would have to go through the standard medical device approval process under FDA guidelines.
Which you know well.
Professor Farahany said it in class. Is there any merit to a proposal like that where it's taken away from being a recreational product and kind of classified as a smoking cessation medical product?
So, yeah, wait, I'm gonna come back to you guys. I'm gonna do 3 questions in a row, and then I'm gonna give each of you an opportunity to respond. Yes?
For cities and schools that have banned these devices, I'm just curious what enforcement looks like and any potential kind of ethical concerns about criminalizing these devices or disciplining people for addiction.
Okay. And sir, in the front, did you have a comment?
Yeah, so in the European Union, the nicotine content of e-cigarettes is only threefold less than here in the US. The US products are much more highly addictive. Is it going to be recommended that the US should also reduce nicotine content in concert with reducing nicotine content in combustible cigarettes? That's the plan of the FDA.
All right, so slightly different, but all on the policy questions. And so why don't we go down the row? I'm going to start at the other end. Each of you have about 1.5 minutes to have your response and closing arguments.
So I'll, first of all, I love the idea of bringing e-cigarettes into a clinical setting. Patients who use nicotine gum or lozenges outside of the medical realm really don't improve their abstinence rates. When I work with patients, I typically would like to get them off of everything, but there are a handful of cases that are just absolutely impossible, and e-cigarettes seem like a good option. A lot of hand-holding with an e-cigarette makes a big difference. In terms of punitive measures, wow, you've got to be really careful because nicotine is highly addictive, and when you start bringing punitive measures to bear on people who cannot overcome an illness, then you get into really shady waters. You get into really tough stuff. Here at Duke, the way we have kind of navigated that is to say that there is no penalty for smoking on campus. However, if your manager says you can't smoke and you say, tough, I'm gonna anyway, then you can get written up for insubordination. And so it essentially follows a pathway that sidesteps the whole issue, frankly, because it's tough, because it's an addictive substance.
So it might sound like a good idea to bring e-cigarettes into the medical model of drug approval, but it's really not going to work to do that. And we know this from experience because drugs go through CDER, Center for Drug Evaluation Research at the FDA, which has taken the most obstinate stand toward e-cigarettes to where for years we were blocked from doing any e-cigarette research in the United States. Why? Because to do any human study, they require 2 species of animal chronic inhalation toxicology, which is hundreds and hundreds of thousands of dollars and time, resources that no academic lab had. And on the other hand, the Center for Tobacco Products uses as the standard the comparison to combustible cigarettes. And as long as you can make a reasonable case something is not worse than combustible cigarettes, they will allow studies to go ahead. So CDER is not the way to go. And then eventually you get something by prescription only, which is not going to reach the masses. It should be treated as a consumer product to compete with cigarettes, which are consumer products, and give advantages to the e-cigarettes. And this gets to the other point, is I don't think it would be productive to mandate a reduction of nicotine in e-cigarettes. Mandate the reduction in the combustible cigarettes to make them unappealing, and then allow the e-cigarettes to be an attractive competitor. Neil Benowitz has made the argument, which I think is very logical, that the higher the concentration of nicotine in an e-cigarette, sure, it may be more addictive, but on the other hand, you have to take in fewer toxins from anything else to get your dose of nicotine. And even what is called the high nicotine arms race, according to one CNN story, Juul only just approaches the nicotine content of good old cigarettes that are freely sold. So I don't see any advantage to making e-cigarettes unappealing by reducing the thing they have, which is the nicotine, and even the appealing flavors that give smokers a reason to turn toward them and away from deadly burning tobacco sticks.
Great, and the last word with Dr. Pacek.
Right, so Yeah, given that e-cigarette products are regulated by the Center for Tobacco Products, unfortunately, I don't think that introducing them as a medical device, as regulations currently stand, is really going to be feasible, unfortunately. And regarding the enforcement of bans on ends and flavored ends, apologies if I'm wrong, but I believe that the bans are on the sale of the products and not the possession of them. So it's not like the people who are vaping are going to be fined or jailed or whatever. It's that the stores cannot carry them. And regarding reducing nicotine content in ends, we actually have some, similar to the hypothetical data that I presented, we had also asked people about what they thought that they would do in terms of their e-cigarette and combusted cigarette use in response to a nicotine reduction policy in ends. Not surprisingly, they said that they would reduce ends use but increase combusted cigarette use. However, whenever a nicotine reduction policy in ends was paired with a simultaneous ban on menthol cigarettes among menthol smokers, you saw intended suppression of both e-cigarette use and combusted cigarette use. Which I also, for the record, am a big proponent of a very low nicotine content product standard in combusted cigarettes. So it's my thinking that simultaneous regulation of these products may lead to the best outcomes.
Great. Thank you to the panelists for a wonderful discussion.